Hello and thank you for viewing our lecture. This is Dr. Christopher Kellner presenting with Dr. Sean Levine, describing endovascular Hunterian ligation. In this chapter, we will describe the origins of endovascular Hunterian ligation and show that parent vessel sacrifice was the first effective treatment for peripheral and intracranial aneurysms. Endovascular techniques have made parent vessel occlusion possible and safe when paired with balloon test occlusion and/or cerebral reserve testing. And flow diversion has made revascularization possible in many challenging cerebrovascular conditions, decreasing the need for permanent vessel occlusion. Hunterian ligation derives its name from John Hunter, who was a Scottish surgeon who lived from 1725 to 1793. He was the first to perform proximal ligation for the treatment of a distal aneurysm. He ligated the superficial femoral artery to treat popliteal aneurysms. In 1808, Sir Astley Cooper performed the first successful carotid ligation, and then in 1885, 100 years after John Hunter, Victor Horsley ligated the carotid artery in the neck to treat an intracranial aneurysm. In the early and mid-20th century, devices were developed to accomplish progressive occlusion of the common and internal carotid arteries. In this image here on the left, you can see a Silverstone clamp placed on the common carotid artery, which is placed during an operation and then progressively occluded while the patient is awake to evaluate the patient's tolerance of carotid occlusion. While the Silverstone clamp was the most commonly used progressive occlusion clamp, a number of clamps were developed and used in the mid-20th century. One of the largest series evaluating progressive carotid occlusion is that performed by Leicester Mount, using the Silverstone clamp in 65 patients undergoing internal carotid, common carotid, or common and external carotid occlusion for the treatment of giant intracranial aneurysms. This study showed that 27 patients had to have their clamp opened, and therefore approximately 50% could not tolerate progressive carotid occlusion. In summary, Leicester Mount found that the results of this study were disappointing, with a high mortality and morbidity for progressive carotid occlusion. There is a modern Silverstone series published in 2012 in which 27 patients underwent carotid occlusion for the treatment of giant ICA aneurysms, in which the authors reported 0% mortality and 22% morbidity. Here's a photograph of the Silverstone clamp used in that case series, and one can see how with turning of the knob, the clamp could be progressively occluded over time. The most extensive experience with Hunterian proximal arterial ligation for giant aneurysms is from Drake, Peerless, and Ferguson from 1994. In this series, they treated nearly 400 patients with Hunterian proximal occlusion. They used a variety of occlusion techniques throughout the experience, including use of the Silverstone clamp, balloon occlusion, detachable balloon occlusion, and intracranial trapping. Authors reported good clinical outcomes in 84% of patients with anterior aneurysms, even including those who came in with poor condition. With that extensive history, we now move into the modern era and discuss endovascular Hunterian ligation. As with the Silverstone clamp, the key to the success of Hunterian ligation is to evaluate which patients cannot tolerate carotid occlusion. One of the first protocols to evaluate endovascular Hunterian ligation using carotid balloon test occlusion was the protocol by Van Rouge and colleagues, published in 2000. In this series, they looked at 29 patients with giant intracranial aneurysms who underwent temporary balloon occlusion of the carotid artery, and they showed that 17 of 25 patients, or 68%, demonstrated radiographic and clinical tolerance of balloon test occlusion. The authors went on to develop a protocol to predict which patients, based entirely on angiographic testing, were likely to tolerate therapeutic occlusion of the carotid artery. The authors reported 76 angiographic test occlusions performed in 74 consecutive patients. 51 of 54 patients who passed the test underwent permanent occlusion. Only one patient who passed the angiographic balloon test occlusion developed symptomatic and radiographic ischemia. Therefore, the positive predictive value of tolerance to permanent occlusion after passing this angiographic test was 98%. Therefore, what Van Rouge and colleagues and others effectively demonstrated is that to successfully perform endovascular Hunterian ligation, it's important to evaluate whether a patient can tolerate permanent vessel occlusion, whether performed suddenly or progressively. Numerous other techniques have been developed to evaluate cerebral reserve testing, including EEG, neurophysiologic monitoring, stump pressure evaluation, near-infrared spectroscopy, transcranial Doppler ultrasonography, PET scanning, and xenon-labeled CT. Now, in the modern era, with appropriate endovascular testing and cerebral reserve testing, endovascular Hunterian ligation has 4 main indications: for the treatment of complex aneurysms, occasionally giant aneurysms, for the treatment of vascular lesions related to trauma, for the treatment of arteries in which there's tumor invasion or need for a tumor surgery that may put the artery at risk, and infection of the artery. The Japanese Registry of Neuroendovascular Therapy reports the largest series of parent artery occlusion for unruptured cerebral aneurysms. In this series, the authors reported the results from 274 patients with unruptured aneurysms. The authors report aneurysms that were approximately 50% in the anterior circulation, in which those were predominantly in the cavernous region, and 50% in the posterior circulation, in which the majority of those aneurysms were in the vertebral artery. The authors reported endovascular techniques including internal trapping and proximal occlusion. They reported a very high success rate of nearly 100%, a low hemorrhagic complication rate of 2.5%, and a fairly low ischemic complication rate of 17.5%. The 30-day morbidity in this series was 11.3%, and the 30-day mortality was only 0.7%. While a number of devices have been put to use to accomplish the goal of permanent artery occlusion, 2 devices have been specifically developed for this purpose. The device on this slide is called an MVP device, or a microvascular plug. This is a basket that's delivered through a microcatheter with a partial PTFE covering, which is polytetrafluoroethylene, also commonly known as Teflon. This device comes in a variety of sizes, and you can see on the bottom here the target vessel diameter ranges from 1.5 millimeters to 9 millimeters. This is used in both intracranial and extracranial procedures. Here's a video taken from the product website demonstrating the function of the device. A microcatheter is advanced into the target artery. The device is advanced through the microcatheter. The device is then deployed in the target artery and expands to completely fill the lumen of the artery. It can then be adjusted to the ideal location. Angiography demonstrates complete occlusion of the vessel. Then the microvascular plug is detached using this motion shown here from the pusher wire and remains permanently in the artery. A second device that has been developed to accomplish permanent vessel occlusion is called the POD system, or permanent occlusion device. This is a very long coil with 2 segments, an anchor segment and a packing segment. The coils in the anchor segment have broad loops which put some lateral pressure on the artery wall to anchor the set of coils in that location. That's followed by a packing segment, which consists of a space-filling liquid metal coil that provides a high-density coiling to accomplish permanent vessel occlusion. Here you've seen the microvascular plug, and here is the pod system. These can be used in combination and can also be used with liquid embolics to accomplish permanent vessel occlusion. Now we will review 3 cases to demonstrate use of endovascular occlusion for various disease processes. Case 1 is IC occlusion for a tumor. This patient is an elderly male with multiple medical problems, including end-stage squamous cell carcinoma of the bilateral neck. The patient was treated with radiation and chemotherapy, then presented for evaluation of enlarging neck mass, for which he underwent surgical debridement. The tumor was found to be encasing the carotid artery bifurcation in the surgery, and bleeding was encountered. After hemostasis was obtained in the operation, the patient was taken emergently to angiography for balloon test occlusion and possible carotid takedown. In this image on the left, you can see diagnostic cerebral angiogram of the common carotid artery on the left, and you can see the surgical clips around the common carotid artery. Here in the right, you can see the balloon occluded, the balloon deployed and occluded in the Petrus segment of the left internal carotid artery. On the left in this image, you can see a right-sided internal carotid artery injection performed prior to inflation of the balloon. And then on the right, you can now see with the balloon inflated, there is excellent cross flow of circulation from the right to the left. In the figure on the left here, you can see there is a microvascular plug deployed in the petrous portion of the internal carotid artery. Here you can see that right here with the tines of the MBP visible. Then you can see more proximally, coils have been deployed in the petrous segment and the distal internal carotid artery cervical segment. In the middle image, you can see that additional coils have been deployed in the distal ICA. And then in the third image, you can see there's a much more extensive coil mass as additional pods have been deployed. You can also see in this image that there's decreased flow through the coil mass with some slowing of flow, but still distal perfusion. Here's a diagnostic cerebral angiogram of left common carotid artery demonstrating decreased flow, but still some distal flow through the left internal carotid artery, even after deployment of a microvascular plug and numerous coils. Here's another diagnostic cerebral angiogram performed after additional coiling, and here you can see that there is complete occlusion of the artery. Coiling was continued down to the common carotid artery, including coiling of the external carotid artery, to accomplish arterial takedown in the region of the tumor. This second case is the story of a patient with a ruptured fusiform vertebral artery aneurysm. This is a healthy middle-aged woman who suffered acute onset of the worst headache of her life, accompanied by severe left neck pain, and presented to the hospital neurologically intact. This figure demonstrates the patient's initial imaging and final post-treatment imaging. In figure A, you can see some subarachnoid hemorrhage in the cerebellopontine angle. In figure B, the aneurysm is shown, and this is seen to be a distal vertebral artery aneurysm. Diagnostic cerebral angiogram in figure C shows the aneurysm as a V4 vertebral artery aneurysm. Image D shows a lateral of the diagnostic cerebral angiogram showing a fusiform artery aneurysm. And then image E is post-occlusion using coiling of focal permanent artery occlusion at the site of the aneurysm. And this is injection of the contralateral side, showing that there's no backfilling beyond the aneurysm. Image F shows the same thing from an AP perspective, that there's no aneurysmal filling from the contralateral side. At this point, there was also no filling from the ipsilateral side. This patient was completely treated and did well, recovered with no neurologic deficits. The third patient we're going to show is a middle-aged woman who presented with sudden onset of severe headache. CT demonstrated a diffuse thin subarachnoid hemorrhage. Initial diagnostic angiogram did not reveal an aneurysm. A second angiogram a week later revealed a distal pica fusiform. Here, figure A was the initial angiogram performed that demonstrated normal cerebrovasculature. In figure B, in the angiogram performed at a later date, you can now see that a fusiform distal pica aneurysm is visible, highlighted by the black arrow. In figure C, you can see the coil mass deployed directly in the aneurysm and the microcatheter used to deploy the coils. And then in figure D, an MRI performed at long-term follow-up, you can see that there was no associated stroke in the pica territory. This brief video demonstrates a microcatheter injection at the location of the aneurysm prior to coiling. And if you watch closely, you can see some backflow from distal collateral circulation. Here's an angiogram after occlusion of the aneurysm with coils, now demonstrating that that segment of pica is completely occluded. That concludes our lecture on endovascular Hunterian ligation. We hope you've enjoyed this talk, as well as the accompanying chapter. Thank you.